to move to a couple cases, and I'm actually going to hand this over to you, Michael. And we're going to start with case number 1.
So this is a 74-year-old gentleman that presented to our clinic with bilateral lower extremity rest pain. He had the classic risk factors for peripheral arterial disease: hypertension, hyperlipidemia, coronary artery disease, and some CKD. Previously undergone a PCI, and on exam, he had a diminished right common femoral pulse and an absent left common femoral pulse. Arterial non-invasives were consistent with arterial disease, with ABIs of 0.5 bilaterally and toe pressures in the 50s. So took him for an arteriogram. Don't always get CAT scans for these patients, but you can see here some moderate disease of his right common and external iliac arteries with an occluded internal iliac artery on the right, and then on the left, a maybe 6 centimeter occlusion of his distal external iliac artery. So we treated both sides from a right-sided access. We used an L6 9mm balloon, shockwave balloon, and used 2 atmospheres, 150 pulses on that side, and then used another L6 balloon from the contralateral side to treat the left external iliac CTO, and used 300 pulses on that side, and only had to take the balloons to 2 atmospheres. And you can see that circumferential 360 degrees calcific burden of that left external iliac lesion, and ultimately ended up placing 2 self-expanding stents, and excellent result. More importantly, the patient's symptoms resolved, and he's doing really well at follow-up at 6 months.
And can I ask you, okay, we go back real quick, so first up, 2 ATs, and we all know if you're going to have a death on the table in the peripheral vascular space, it's going to be perfect in iliac artery. So starting low, still effective therapy because they're sized appropriately, but great luminal gain off of, looked like half the pulses on one side and the other. Second thing though, you had a CTO. How was it delivering that device up and over to get to the contralateral side?
Yeah, I think that the shockwave technology is really easy to deliver, even below the knee, but especially in the iliacs. You don't typically need to pre-dilate to deliver these technologies. Even though one of the nice things about L6 is, compared to the other shockwave technologies, which are all 014 platforms, the L6 allows you to deploy it and deliver it over an 018 platform. So you have a little bit more stability and rigidity that allows you to sort of cross these tighter, even CTO type lesions.
Yeah, great comment. I think that's a big plus. 018 platform has definitely helped on the iliac space as well.
Yeah.
Great case.
You feel a lot better, and then obviously worst case scenario, you cause a vessel rupture. Delivering a 018 Viabon is a lot easier. You feel a lot more comfortable doing that than having an 014 floppy little flimsy wire and needing to move expeditiously. It gives you a lot of security.
Yeah, great comment. Yeah.
So this is another case in a different location where we use a shockwave technology, and this is I've got close to 10 patients who are their own control. So this is a 61-year-old man who I had previously done a left iliofemoral endarterectomy, who presented back to clinic 6 months later with right lower extremity rest pain. He has all the same types of comorbidities, some heart failure, history of stroke. And on the left, his ABI was 0.99, and on the right, his ABI was non-compressible with a toe pressure or TBI of 0.4. Palpable pulses on the left, non-palpable on the right. So I anticipated finding the same sort of calcific disease that I treated on the left on the right. So I asked the patient, we can do the exact same thing we did on the left, give you an incision in the groin, or we can try something that probably doesn't have the same sort of data that we have for iliofemoral endarterectomy, but we can try it and see if this delivers you a good result. And obviously, if it doesn't work, we can always do the same thing again. So we took him. He agreed to try the minimally invasive option. You can see here, it's a pretty gross-looking exophytic plaque in that common femoral artery, distal to the profundifemoris and the superficial femoral artery. And I'm going to be honest, I was a little hesitant. I wasn't entirely sure how good any percutaneous technology would work in this type of environment. But sure enough, M5 plus, 8x60, 300 pulses, taken to 4 atmospheres. Followed that up with an impact AVF DCB, one of the larger diameter ones.
Love it.
9 millimeters, 6 atmospheres. And when we took our completion angiogram, there were audible gasps. It was pretty remarkable to see this type of result from a procedure that took less than 40 minutes to do. More impressively, on follow-up duplex, it's as if there was no calcific disease there, with excellent waveforms in that right common femoral artery at 1 month. And he continues to do well bilaterally at a year, with an ABI of 1.2 on the right, which previously was non-compressible, and an ABI that remains 1 on the left. So this is a great example of how this technology can work in areas historically been reserved only for surgery.
Yeah, that's a great example. And again, if you think about an area you don't want to dissect and stent, common femoral is probably one of them. Now, you had a nice anatomic location of that disease, but it was avoiding the bifurcation with the profunda, so it gives you a little comfort for considering an endovascular treatment. But you know, you have to consider putting in a Supera or some other technology if you're going to stent across and involve the inguinal ligament and into that fold. And so that's like brand new. I mean, that you can't beat that case. So
Yeah.
And sized well also.
Yeah, and I think that we finally have specialty technologies that can address larger vessels, right? You know, people have done a lot of atherectomy, people have done a lot of stents, people have done a lot, even some DCB studies looking at common femoral disease. But historically, we haven't had technologies to appropriately size for those vessels.
Absolutely.
Now we do.
Yeah. Yeah, I don't think anybody could argue with that outcome there. That's a textbook case, so that's really wonderful. I'm gonna go a little bit lower now. So we did 2 great iliac cases. This one's a popliteal and a distal tibial vessel, and so this is a gentleman I took care of. I kind of have an agreement. A lot of our podiatric surgeons do our minor amps and other types and TMAs, and so they'll get a lot of referrals for amputations, and we kind of have an agreement if an endovascular or surgical revascular treatment wasn't attempted to call and at least let us consider it before they do something. So this is a patient who had been referred already for a failed attempt at opening a popliteal occlusion, sent to podiatry, was going to start with probably just a local amp, but you'll see in a minute why that would never have worked. And we thought, let's give it one more time before we destined this guy to probably what was going to be needed to be a below-the-knee amputation. So this is the angiogram. You can see that in a typical diabetic patient, he's got a fairly normal SFA, and then all hell breaks loose after that, and I'll let this keep playing. But you can see the pop occlusion here, really poor runoff. And this is, a great case where, DVA is something that we would consider. It was a little too proximal, really, for us to think about DVA here. Surgical bypass, we really had poor filling distally to understand what our distal bypass options were. And then we scan usually a lot of these with EVAS, external ultrasound. And I was thinking maybe I can get into the AT, and you can see a little ghosting of the AT there, but really the dominant vessel to the flow would end up being the perineal. That's the largest vessel. So we thought, let's just try to get perineal flow, see if we could get that to heal, at least buy some time, understand if we have other options that might be needed, like distal bypass later, but this would be a good way to start. And so we always prep antegrade and then if needed, retro. And here we said, let's give it a chance, antegrade. If we can't get that, we'll go retro and see if we can get up retro. Single vessel runoff. I don't love sticking that vessel if I don't need to, but I will. And so we end up taking some advanced wires. Again, I kind of, what I like to say to my fellows is I go coronary on this. This is a bunch of coronary specialty wires, but we're able to really navigate this wire, starting with just kind of a run-of-the-mill wire we use in the coronary space called a fielder wire. But then we use this Estado wire, and this is also known in the periphery as a heavy tip load wire. We do everything really closely to a crossing catheter to really maximize the ability to control the wire and also maximize the tip load on the wire. And you'll see here that we're following closely with a quick cross, and we find a nice path. And I'm kind of using tactile feel here. I know I'm kind of moving the right way. You see us taking a few pictures to make sure we're on the right path. And I ended up finding the AT, and I knew the AT was occluded, but I said, you know what, let's take what they gave us, and let's take a look at where we are with IVUS, understand what this disease process is, understand if I'm subintimal or not, and then we'll go from there. And so we end up passing an IVUS catheter. We're 0-4 right now, so it's an 0-4 catheter, and you'll see the IVUS catheter coming through really nicely here. No real vessel prep at this point. And my goal, ideally, instead of taking a distal shot with some contrast to a crossing catheter to see if I'm luminal, I prefer not to, because every couple times when you do that, you end up being subintimal, and then you just fill in the subintimal space with contrast and blood. And so I like to try to IVUS if I can, and you can see nicely on the image here, I'm luminal. You can see that calcium burden, which I really could not see on that image. I had to assume with diabetes and some kidney disease I was going to be there, but didn't realize to appreciate the amount of calcium. And you can see I'm pulling back here now through the AT up into the popliteal artery. And I seem to be pretty luminal, if not the whole way, the major extent of it. Here I'm pausing, just looking at the disease. You can see now coming into the popliteal artery, and then that concentric calcium that really was plaguing this patient with a lot of other fibrocalcific disease more in the lumen. So IVUS here, told me a couple things. It told me that I'm in the central lumen, I'm not subintimal, so I have a lot of options for treatment. Gave me some understanding of sizing, and then it also gave me that real knowledge of how much calcium existed here. So we went thinking that we were going to try to balloon and potentially DCB, to thinking, okay, we're going to need a vessel prep, we're probably going to need a stent, and what do we want to do for sizing? And so here we did angio-based sizing and then IVUS-based sizing, and you can see that we were off by about just under a millimeter for both of these if we use just our angiogram based versus a healthy reference for our IVUS-guided sizing. So we ended up sizing the tibial perineal trunk at about 3.7 millimeters, the popliteal rounding up to 5 millimeters. We want to make sure we approximately round it up a little bit for our devices. And so the next thing we did, just thinking that we wanted to make sure we understood the vessel we were in and clear some space, we used the IVUS to find the origin of the perineal artery. And then we just buddy wired it. And that didn't take long. You see I'm Jade here. It was pretty easy to get into that vessel. We did a little bit of angioplasty just to get some luminal flow. And you can see still here, we were undersized with that balloon angioplasty, 4 millimeters. Really not much flow across the popliteal, and a little trickle flow now into that perineal artery. So what did we do next? We saw the calcium. We had sized appropriately. We were thinking that we're going to need a stent. We do not want to put in a superior stent that doesn't have a very well prepared vessel. We've all done that before. So here we end up going with the S4 4x40 into the tibial perineal trunk, and then the M5 up from the popliteal artery back. And you'll see the image on the right here, following just the shockwave at 2 to 4 atts, using the full range of the lithotripsy. We have a really nice channel now, and that you can see how much that perineal artery, tibia trunk, perineal artery grew. So we were thrilled at this point. We thought we'd be able to solve this case. So I went and placed a 5.5 millimeter supera across the popliteal, again, sized a little bit larger than I saw in IVUS, and I thought I had everything covered. And I take this angiogram on the left, and the contrast is just stuck to the bill of the stent. My fellow looks at me, and he's like, now what? And I was like, oh, let's understand this before we overreact. So we went in with IVUS, and we pull back again, and we see that we really just had a geographic miss distally, and we had a lesion there still at the outflow of the stent that was limiting the rest of this. There wasn't much dissection. You can see it right here. I pause here where that disease is that we missed, and then you'll see on the IVUS image in a moment that my stent comes in and looks nicely well expanded, and we got to work on it a little bit, but you'll see good approximation here throughout the rest of the popliteal. So what we did was we snorkeled another stent to cover that diseased area into the perineal trunk. You can see we really get a nice final image here. So you can see after we put in those 2 stents on the left here, we can see great flow down that popliteal artery occlusion, really nicely into the perineal artery. Throughout the length of the perineal artery, really nice collaterals. You can see how much better that patient's going to feel. And then flow down to the wound in the foot, collateralizing both the distal AT as well as the PT. The patient did tremendously well in follow-up, wound healed completely. We've now followed him about 8 months, and even out to 20 months now, those stents are still open, patient still asymptomatic. And again, he was a mix of both rest pain and ulcer, and he feels fantastic. All right, so, we've talked a lot about sizing here, and in both of our cases, we've appropriately sized IVL to the vessel wall, but then we've also both taken definitive treatments a little larger even than the IVL. Any thought on your thinking there? And I'll share mine as well.
Yeah, so I think for my common femoral case, I was using the M5 Plus. I didn't have access to L6 at that time, and I think I would have been very comfortable using one of the larger 9 millimeter L6 balloons to treat that common femoral artery, and then subsequently use a 9 millimeter drug-coated balloon to treat that artery. But I think at the end of the day, Shockwave delivers its therapy at low pressures, but you deliver a high degree of therapy. And using a balloon or a stent that's slightly larger is something that you're very, very comfortable doing because the compliance of the vessel has changed. You've treated that medial calcium like you've alluded to or you've talked about, today. I think it just makes it a very safe way you can deliver care.
Yeah, those are great comments. I agree completely. And when you think of 2 definitive treatments that we use routinely, whether it's a self-expanding stent or a drug-coated balloon, the self-expanding stent, oversizing is okay because the vessel is going to somewhat constrict that stent and allow it to conform to the vessel size. And we'll post-dilate a little bit, but oversizing with a covered stent, as long as you have a good understanding of your reference landing zones, it's going to be an appropriate way to treat. And like you said, restoring that normal vasotone to the vessel with the IVL balloon is an important component for that. For drug, and I made the comment at the beginning of our conversation, drug only works if it's touching the wall, and I always want to be sure of it. And so Again, an average DCB has a 6 to 8 atmospheric reference point for treatment, and I love to be large on that. I want to get all the drug off the balloon to the vessel wall. So Shockwave gives us the comfort of creating a vessel that feels like a normal, healthy vessel, just like you showed in that duplex ultrasound after your common femoral intervention. And then it gives you really whatever you want to do definitively afterwards. Sizing a little larger makes it feel comfortable because you're not in that heavily diseased, pre-treated area that you're not sure what you're going to get next, dissection, perforation, whatnot.
Yeah, completely agree.
Well, Michael, this has been a fantastic discussion. I think that I learned a lot from you. I think that really reviewing the principles of an effective way to use intravascular lithotripsy complemented by imaging devices like intravascular ultrasound really is the right way to move forward with this technology, improve the likelihood of benefiting our patients over the long term for lower extremity interventions. And I really, really appreciated your cases. So thank you very much for joining me in this discussion today.
Thanks so much, Eric. It was a really good time. I learned a lot.